Okay guys, so this is the second lecture in our Biostats for Sports Medicine series. So last week, if you remember, we went over these things, so pretty basic stuff, more kind of nuts and bolts of statistics. So this week, this is the outline. So we're gonna go over, we sort of finished off like comparing means of 2 or more different sets of samples. And so we're gonna start off looking at categorical data as the outcome and see how we're going to compare that. Just very briefly, some high-level stuff. We're going to look at prevalence and incidence rates, look at how to compare the actual size or the effect size between two means, or between two groups of individuals. We're going to look at briefly different types of study designs, and then go into sensitivity and specificity and likelihood ratio stuff that you've done like a million times, but it's always good to go over again, predictive values, and then briefly touch on regression techniques, okay? So to start, so looking at categorical data as the outcome that you're looking at and how to do inferential statistics on that. One of the basic techniques that you're going to see is a chi-square test. So we'll touch on that and briefly touch on the Fisher's exact test as well and when you would use that. And then look at effect size calculations for categorical data as an outcome. So this is last week. Remember we did the ANOVA, so comparing outcome data that is a mean in nature between 3 groups. So when you look at categorical data, you're now looking at categorical data is both the outcome and the predictor or the group as well. So this is the basic setup for a chi-squared. So this is a 2x2 table. These can get more complicated, and you can have more rows or more columns. It could be R by C as well for chi-squared. But for starters, we'll just look at this. So remember, we talked about hypothesis testing for the chi-squared. The null hypothesis is that the variables, so that's the variable, the exposure variable and the outcome variable, are independent, and the alternative hypothesis simply is that they're not independent. So one is essentially dependent on the other. This is the chi-squared statistic on how you calculate it. We don't have to go into too much detail on how to do it, but essentially what you do is you calculate a chi-squared and then have you compare it to a critical value of your chi-squared, which is based off your degrees of freedom for your test and your significance level that you want to look at, and see if your chi-square that you calculated is greater than that critical value. So like we said, so the chi-squared tells you if 2 variables are independent or dependent on each other. However, it doesn't tell you the effect size, if you will. So it doesn't tell you how big, if you do see effect, how big that effect is. And that's why you need to start using other techniques, such as a risk difference or relative risk or odds ratio, to actually describe how big the relationship is once you identify that there is a relationship. And we'll talk about those in a second. But in order to sort of really delve into those, we really have to just cover the basics. So talk about prevalence and incidence and what's the difference. Does anyone know what the difference between prevalence and incidence is? So prevalence is cases over, like you said, a population at risk or a population of interest. Whereas incidence is new cases in a population over a certain time. And so essentially prevalence is the equivalent of an incidence of the condition times the duration or the time that you're looking at. So coming back to methods of comparison, so this is looking at the effect size. There's a few things that we're going to go over. So risk difference, relative risk, or the absolute risk difference, sometimes called the incidence risk difference as well. Relative risk is also known as the incidence rate ratio, and then odds ratio, and when you would use one and when you would use the other as well. So to start, risk difference, there's a few sort of definitions that we have to go over. So IRE is we're going to define as the incidence of the disease or the condition in an exposed group. So that is a cohort of individuals who has the exposure of interest. The incidence, so IRNE is the incidence of the condition or the disease in individuals who were not exposed. And simply the incidence risk difference is the incidence in the exposed minus the incidence in the not exposed. This is an absolute change, so it's not a relative calculation, so it's the absolute change in risk based on exposure or not exposure. Similarly, so another way of calling this is the absolute risk difference. Again, so it's the rate in the exposed versus the rate in the unexposed. So rate is another way of saying incidence. And so the next thing you can use, and where this is used frequently, is to calculate a number needed to treat. So the number needed to treat is actually 1 over the absolute risk difference, or the incidence rate difference. And this is essentially the number of individuals required to be exposed in order to prevent one of the outcome, one of the condition, one of the disease. So we'll look at a case and how they do that after we go through relative risk. So this is more of a ratio. So this is a relative comparison. So you're looking at the incidence in the disease divided by the incidence in the exposed divided by the incidence in the not exposed, and this gives you a relative risk of the exposure, or the relative risk of having the outcome of interest in the exposed compared to the unexposed. So what's the advantage of doing a relative versus an absolute comparison? Relative risk is probably more frequently used in the absolute comparison, so it's more understood in the general literature. And what's also good about the relative risk is you can estimate it using an odds ratio if the prevalence of the disease is very, very low. Some disadvantages, however, are sort of highlighted by this case here. So in both these two cases, the relative risk is 2. But in conditions where the prevalence of the disease is very, very high, or the prevalence of the condition is high, it might actually underestimate the actual difference that you see. So for example, 20% versus 10% versus is going to give you a relative risk of 2, whereas you're going to get the same relative risk if the incidence in the exposed is 0.2 compared to 0.1. So sometimes you've got to be careful looking at the relative risk, and sometimes it's useful to look at the absolute numbers to see what the change is and whether that's going to be clinically relevant or not. All right, so this is one paper that we're just going to go through just to highlight some of these items. So this was a cluster randomized control trial looking at eccentric training programs to see if there was an effect on those, hamstring injuries for those who were exposed to this program. So what they did is they took 54 teams and they randomly allocated them to either receive the intervention, which is the eccentric training group, or to just be part of the control group, which didn't receive any intervention at all. And essentially this is what they found. So this is their table 3, and it looks like a lot. So what we're just going to focus on is this total, these 2 rows underneath the total here. And you can see, so in the intervention group they had 15 injuries, and in the control group they had 52. So what I essentially did was just made a little 2x2 table based on this, so we can kind of start calculating some of those numbers and see where they came up with their number needed to treat and their rate ratio. So in this group, how would you calculate the incidence in the exposed? In the exposed being the intervention, the eccentric. Yeah, so that's correct. That's one way of doing it. The thing is, in sports medicine, to really figure out the incidence, people use a lot of different techniques. So in this case, you can see this number here, player seasons at risk. So what they really want to do is just control for the amount of seasons that each player was exposed to. So essentially, this was run over one season, but not each player played an entire season. So that's why you see that this number is a little bit lower than the total numbers, because some players might have dropped out, some players may not have played, some players might have been relegated to a lower league. So for whatever reason, not each player got the full exposure of one season. So in that case, they use the denominator as this player seasons at risk. And people do this in a number of different ways. So you just got to kind of figure out how they calculate their denominator. There's no standardized way of doing that in sports medicine. So you're right. So that's the incidence of a hamstring injury in the players who are exposed to the eccentrics training program. So similarly, the unexposed would be 52 injuries over their player seasons at risk, which is 396. And then the relative risk, like we said, is the incidence in exposed over the incidence in the unexposed, and that's where you get your 2.92. So that's how they got their unadjusted rate ratio. The adjusted is when they start doing modeling and they control for other factors, which we're not going to go into too much, okay? So that's how they got that number. And so what you have to do when you see a table in a paper, sometimes they don't provide the full 2x2 because it's a little bit redundant when they give you all this other information. So if you really want to sort of delve into the numbers, you kind of just have to do it yourself. So now, if you want to calculate the number needed to treat, what they did, and I don't really know why, is they used the actual total numbers to do this. And I'm not entirely sure, it wasn't clear in the paper, but what essentially did, so they calculate the incidence in the exposed, the incidence in the unexposed. So the absolute risk reduction is going to be 0.032 minus 0.108. And you can see that this is a negative value, so there's been a reduction in risk, a reduction in incidence based on the intervention. And to calculate the number needed to treat, you just do 1 over that number. So this would be a negative value, but that just switches whether it's a number needed to treat or number needed to harm. One issue is if this is how they did calculate this number needed to treat, what you really should do is whenever you calculate a number needed to treat is round up to truly, because this is 13.1, you can't include sort of a tenth of a patient. So what you should do is always round up to the next highest integer. So this really should be 14 if this is how they did it, just to truly include, because you actually need to avoid one hamstring injury. You can't say we're going to treat 13.1 players. You have to say 14, right? So that's just a breakdown of how they did that. So pretty basic stuff. All right, so let's talk about odds ratios a little bit and when that comes up. So you use an odds ratio when you can't actually calculate a prevalence or an incidence, and that happens in case control studies because you're defining your cohorts based on the outcome. So you don't actually have a true denominator of individuals who were the population at risk to begin with, and then deciding who developed the condition, right? So you first define them by the outcome of interest. And an odds is just a funny way of defining sort of probability. It's not probability, but equivalence to probability. So for example, an odds of 3 to 1, you would say that's an odds of 3, and that's sort of 75% compared to 25% within a cohort. So the ratio of two odds is obviously the odds ratio, and the odds ratio is actually useful because in conditions that are very, very rare, it actually approximates the relative risk quite nicely, so that's why it's useful. So this is coming back to our 2x2 table, so it looks very similar, and based on this table alone, you wouldn't be able to differentiate what a measure of effect, whether a relative risk or an odds ratio you should use. It's really based on the study methodology, and that kind of defines what effect size you should use. And to calculate the odds ratio, you first of all calculate the odds of having the exposure in individuals with the condition. So that would be A over C. You guys see how that works? And then the odds of having the exposure if the disease is absent, which is B over D. So the odds ratio is essentially the A over C over B over D, and when you just work out the algebra, it's A times D over B times C. All right, so this is coming back to study design a little bit, just to kind of highlight a little bit more when you can use an odds ratio and when you can't. So the two sort of major epidemiological study designs are a cohort and case control. So a cohort is when you define your cohorts at the start of the study based on the exposure. So you're saying these individuals have the exposure, these individuals don't. Let's follow them either forward, or you can do this retrospectively and identify which individuals then develop the condition of interest. So based on that study, you can actually estimate incidence and prevalence, so you can actually develop a relative risk. Like we said before, case control, you actually define individuals and define your cohorts based on the outcome of interest. So you actually don't know what population, the true breadth of the population was at risk to begin with, so you actually can't estimate your denominator, so you actually can't estimate an incidence or prevalence, so you have to use an odds ratios for that. When would you use one, when would you use the other? So case controls are good for rare outcomes and identifying what exposures might be associated with those, and cohorts are good for rare exposures. Cross-sectional studies are essentially looking at a population at one point of time, and you're measuring the exposure and the outcome at the same time. Ecological studies are looking at sort of populations at a very broad level, sort of nationally or internationally, and looking at exposures associated with your broad sort of geographic borders. And there's obviously randomized controlled trials as well, which I think we're all familiar with. All right, so this is looking at a case control study and how they came up with their odds ratio. So this is a study that looked at ACL tears and tried in female athletes and tried to see if there was a relationship between the menstrual phase and the risk of ACL tear. This is essentially how we're going to calculate their 2x2 table. So it's the way that they actually presented their data wasn't actually that intuitive and that clear. So the way they did, so this is how they define their cohorts. So ACL versus control, or individuals without an ACL, and they tried to define where the females were in their menstrual cycle, and what they were particularly interested in looking at, whether they were pre-ovulatory or post-ovulatory. And this is the percent of females in this phase when they had their injury, and this is the percent of females in these phases when they were measured as controls during the same time, the same risk period. So based on the sample size that they gave us, so 46, so not a huge study, but 46 had ACL tears and 45 didn't. This is our 2x2 table, and I essentially just multiplied the prevalence, the percentage by the total sample size in each. And so this is the 2x2 table for this quadrant right here. So based on menstrual history, so just talking to the patients when their last menstrual period was, and they identified that they're pre-menopausal at that time, based on history. This is essentially a 2x2 table expansion for this one little quadrant right here. So if we look at doing our little odds ratio calculation, so essentially you take the odds of having a pre-ovulatory menstrual phase in those who had an ACL tear, versus divided by the odds of not being pre-ovulatory in those who didn't have an ACL tear. Sorry, the odds of being pre-ovulatory in those who didn't have an ACL tear, and you found an odds ratio of 2.356, which is pretty close to their odds ratio, but they didn't report unadjusted. They adjusted for age and number of lifetime menstrual cycles in their study. So that's how they calculated theirs, but pretty straightforward. All right, so now we're going to move on to sensitivity and specificity. We've probably done this a lot of times, but whenever you do a diagnostic test, it's going to give you a positive or negative, right? But whether that's a truly positive or truly negative, you don't actually know. It's similar to the hypothesis testing 2x2 table we did last week, whether you're going to sustain type 1 error or type 2 error. So there's four outcomes of a test. There's four sort of possibilities when you get a test result back. It can be a true positive, which means that the test is positive and the disease or the condition is actually present. It can be a false positive. You can think of this as like a false alarm. So the test was positive, but in fact the disease is absent. A true negative is when the test is negative and the disease or condition is not present. And a false negative is when the test is falsely negative. So it says it's negative, but the disease is actually present. All right, so another 2x2 table. So I wanted to throw up all the 2x2 tables that we had so far, just so you can look at all of them and try and remember. So this one here is the middle one, is from, where's my mouse? Is from last week. This is hypothesis testing and type 1, type 2 error. This is the one that we just saw now, so this is totally different. It's about exposure variables and outcome variables. And this is the one we're going to look at now. So this is about disease presence, disease absence, but on the column, on the rows, you're going to have whether the test is positive or test is negative. Okay, so just to look at all those together, so you don't get too confused. So this is the one we're looking at right now. So there's 4 quadrants. So coming back to what we said about the 4 potential possibilities: test positive, disease positive. That's your true positive right there. Test positive, disease negative. That's your false alarm. That's your false positive. Test negative, disease positive, that's your false negative, and test negative, disease negative, that's your true negative. Okay? So, first thing that we want to think about is sensitivity and specificity. And whenever you're thinking about sensitivity and specificity, you can think of this, you think of cutting the 2x2 table based on whether disease is present or absent. So you're looking at the first column versus second column, right? So sensitivity, you're going to look at in all of those individuals who have the disease, how many were actually truly positive. So it's a proportion of disease individuals with a positive test, right? So we can look at, so A over A plus C, or true positive over true positive divided by false negative. So you're looking in the disease column, right? Disease positive column. The specificity of the test is the proportion of the individuals who don't have the disease that tested negative. So again, we're going to split the 2x2 table into columns. So you're looking at the proportion in this column, this quadrant right here, out of the full column. So it's true negative over true negative plus false positive. Okay, so sensitivity and specificity. Remember, you're cutting the 2x2 table in columns based on disease or disease presence or absence. So another way to look at it is this sort of schematic, which is presented frequently. So if this is a population, people with the black dots have a condition, people with the open circles don't have the condition. You're going to run a test. The red result is positive, the green is negative. So obviously you can see that this test isn't perfect. But how does this relate to our definitions of sensitivity and specificity? So to start, remember, so you're breaking based on disease presence or absence. So sensitivity, you're taking all the individuals with the condition or with the disease, and you're saying how many of these actually tested positive based on the test you use. So it's this quadrant here. So in this case, 24 out of 30, so that's 80%. Specificity, so again, breaking based on disease presence or absence, you're going to take all the individuals without the disease and see how many tested negative. So in this case, it's 56 out of 70, or again, 80%. So sensitivity is really good at ruling out a condition, and specificity is really good at ruling in a condition. And depending on what the condition is and what your goals are, you're going to sort of balance the test that you use or the threshold, the cutoff that you use. So speaking about cutoff, so if you remember last week, we talked about changing your threshold, about where you're going to set your type 1 or type 2 error, and you're always going to sacrifice one for the other. It's similar with sensitivity and specificity. So if you change your cutoff and move it further to the right, you're going to increase potentially your false negatives and reduce your false positives, and similarly the other way. Then we come to likelihood ratios. So likelihood ratios take into account sort of sensitivity and specificity and give you sort of a measure of test performance. So what likelihood ratios are really good at doing are converting pre-test probabilities of a test to post-test probability. So pre-test probability of a test is essentially what the probability of an individual having a certain condition or disease before you do any test. And if you don't have any other information about the individual as far as risk factors or exam maneuvers, this can be essentially just the disease prevalence. And then when you do your likelihood ratio, you do your test with a certain likelihood ratio, you can then calculate a post-test probability. And so essentially, like we said, post-test probability is your pre-test probability times your likelihood ratio, or your positive likelihood ratio. So positive likelihood ratio is the odds of a positive test in people with the disease divided by the odds of tests in people without the disease. Another way of calculating is sensitivity over 1 minus specificity. This is kind of your receiver operating, when you graph this out schematically, your receiver operating characteristic for a specific test. But similarly, you can have a negative likelihood ratio when you want to consider ruling out a test, which is the probability of a negative test in people with the disease over the probability of a negative test in people without the disease. So it's kind of the opposite. So 1 minus sensitivity over the specificity. Not too important to get too bogged down with these right now, but we'll see an example of how this is used in sports medicine. I think I got this paper from you, Mark. So this is a paper. It's a review paper that looked at the test or exam sort of characteristics for SI joint pathology. So what they did is they looked at 5 tests for SI joint pathology. We're not going to go through them right now because that's not necessarily the point, but they looked at distraction, SI distraction, compression, thigh thrust, Gainsland's, sacral thrust, and Patrick's Faber. So a Faber test. Is that 6? 1, 2, 3, 4. Yeah, 6. So we looked at 6 tests. And this study in particular was a review of 2. Essentially, they just reviewed 2 studies. So that's why there's 2 columns for each of these. One of them was Laszlo study, and one of them was this Vander Werf study. But essentially, what you can see is that in both these studies, if one of 6 of these SI joint tests were positive, the sensitivity of having SI joint pathology was 100%. Whereas if you go to the complete opposite end, so 5 or more of these were positive in order to make a diagnosis, your sensitivity then dropped to 0 to 27%. So the criteria essentially was much higher. So essentially this just comes back to setting your threshold at what's an appropriate level. So for these particular tests for the SI joint testing, they said having 3 or more of those was the optimal level. For this one particular study, it had a sensitivity of 91% and a specificity of 78%. Picking up SI joint pathology. And I think this is what you're going to sort of start looking into for the exam. You have predictive values, which are a little bit different than sensitivity and specificity. So predictive values break the 2x2 column up into rows. So you're going to look at all the individuals, particularly, so let's start with positive predictive value, and all the individuals with a positive test, how many of those actually have the disease? So it's true positives over true positives plus false positives. The negative predictive value of a test is of all those individuals who tested negative, how many of those actually have the don't have the disease. So it's true negatives over true negatives plus false negatives. And when talking about a test maneuver, say an exam maneuver, particularly in sports medicine, we do that a lot. After you do the test, you've already decided to do a test. Talking about sensitivity and specificity in isolation is not that useful because you've already done the test and you already have the result. What you should be sort of talking about more is positive predictive value and negative predictive value. So if it's a positive test, you should start looking at what is the positive predictive value of this test. The one thing that predictive values that pertain to predictive values and not so much sensitivity and specificity of tests is that predictive values change based on the prevalence of the condition in your population that you're testing on. As you can see, like we said, it splits the 2x2 table into rows. So the prevalence of the disease, whether you have a higher prevalence, it's going to shift more of the cohort into the first column, and so therefore change the positive predictive value of a particular test. So that's one thing you have to take into account. So that's just a review slide, and then regression. So this is the only slide that we're going to do on regression. So you could, people do whole PhDs on regression, but it's essentially a modeling technique that allows you to adjust or control for multiple variables when you want to look at a particular predictor's effect on an outcome. And there's multiple different regression techniques, and it really depends on what type of data you're using and the study design. But things that you might see are, so linear regression is good for looking at continuous variables and outcome. If you're looking at count data, so number of injuries, you really should be looking at doing a Poisson regression. Dichotomous outcomes, you're going to look at a logistic regression, and survival data, you're always going to do a survival analysis. And that's pretty much it. Any questions?